Good afternoon, everyone, and thank you for joining Wayside Recovery Center in partnership with the Minnesota Department of Human Services and our amazing speaker today, Ms. Tamara Moore. I would like to welcome you all to the Maternal Infant Health Series and tell you a little bit more about Wayside Recovery Center as well before we begin. Wayside Recovery Center is hosting these Project Echo sessions in a series in partnerships with Minnesota Department of Human Services, focusing on reducing maternal and infant health disparities. We are running this series through September 2023. This Echo series includes Black maternal health disparities, racism, ACEs, helping mothers prepare for pregnancy. We're hearing from doulas. And then this cohort series 2 is focused more on community. So we will hear from Calvin Williams coming up, sharing a little bit more around fatherhood and how to partner with families and around kinship and also mental health. We thank you for joining us. A little bit more about Wayside Recovery Center. Wayside Recovery Center is a gender-specific care facility. We believe that the needs for women are unique and critical in optimizing their care in our prevention program and treatment program. Wayside has been in existence for over 60 years, and we specialize in empowering women and breaking generation cycles of substance abuse. And in that, we try to provide many internal and external resources for women to be successful in helping in this chronic condition. Wayside is a CCBHC, which means we are a certified community behavioral health clinic, and Wayside provides more services addressing whole health, making them more affordable and accessible to the women in our program. This specific series is being fully funded by the State Opioid Response Grant from the Substance Abuse and Mental Health Services Administration, SAMHSA, and the Minnesota Department of Human Services, DHS. We want to make sure that we share that nothing in these materials constitutes a direct or indirect endorsement by SAMHSA or Minnesota DHS of content, services, and or policies. It is with great pleasure that I will get ready to introduce you to Tamara Moore. Tamara is a licensed social worker with over 15 years of experience and holds a master's of social work degree with an emphasis in program development, policy, and administration. Tamara is currently a policy specialist at the Minnesota Department of Human Services, and her primary responsibilities include developing policy, providing policy guidance, and technical assistance to counties, tribes, and community agencies related to the needs of youth who are expecting or parenting. Additionally, Tamara is a medical social worker for mHealth Fairview System. I would like you to join me in giving Tamara a warm welcome as she presents to us this afternoon. Thank you so much for joining us.
Hello, thanks for joining us, everybody. So I'm Tamara, and I am here to discuss with you the needs of expectant and parenting youth and explore some value systems of which they are served. As mentioned, I have a dual role with this population at the Department of Human Services. I am the policy specialist for all things expectant and parenting youth, and I'm also a medical social worker for the mHealth Fairview System. And so today we'll talk about kind of both of those perspectives, like a social work, child welfare perspective, and a medical social work perspective as well. So we'll be looking at exploring the intersectionality of adolescence and maternity. We will also be looking at the needs of expectant and parenting youth. And then we'll draw our attention to and our awareness to one's values and learn how to explore the values of the people that we serve. We'll begin by going over some terminology, and then we'll dive into the medical social work perspective, looking at some data, looking at some scenarios, and then we'll wrap up with the child welfare perspective. So this is just a basic definition of values. And so today we'll be looking at and be kind of thinking of it in terms of the importance or worth or usefulness of something, or a person's principles or standards of behavior, or an ideal or principle that determines what is correct, desirable, or morally correct. And the basic definition of needs, things that are of necessity or something that a person must have. All right, so this term, expected in parenting use, we just adopted this terminology maybe in the last year. So at the department, we have been doing some work with pregnant and parenting youth, and then we had convened some stakeholder work groups, and there a lot of the questions that we got were, what about the expecting fathers and the fathers that are involved in these cases as well? And so we began using the term expected in parenting youth. And so the population that we're talking about are young people that are 20 and younger, that are either pregnant females or expecting fathers or parenting mothers or parenting fathers. And so, yeah, you'll hear me say EPY or expecting parenting youth. And then I would also say that the reason that we kind of define this population as 20 and younger is because our child welfare programs and our child protection system serve young people up until their 21st birthday. So we say all 20-year-olds and younger. So with some of the data and things that I'll present, it will be about that particular grouping of people. So this is just a snapshot of the general population of females 14 to 20 years old in the state of Minnesota. And this is going to kind of be important with the other data that we'll be presenting. A lot of the data that I have is based on birth records from our Department of Health. So we are just in the infancy stages of identifying those expectant and parenting fathers. And so our data isn't very solid. And so right now we're just using the birth data from the Department of Health. And so these are the counties here in Minnesota that have the highest numbers of births to this population, to 14 to 20-year-olds. And you would see that our largest counties, Ramsey, Hennepin, and St. Louis, are amongst the top 3 there. So this is just helpful for people that may be working in these counties or have some affiliation with these counties, so they can see kind of what the numbers look like. So now we'll jump into the medical perspective of working with this population. All right, so as I mentioned, I am a medical social worker in a hospital setting. And there I cover the mom-baby unit, so the maternity unit and the neonatal units, including NICU, labor and delivery, all of the above. And so typically, we get consulted about which patients we need to see. And we have developed, the care management team, we have developed a list of reasons for a provider to request a consult. And so when that occurs, the provider, either the nurse or the doctor, requests a social work consult, and then they put in some information about why we need to see the patient. And so the social worker then assesses and provides information or resources and assists with discharge planning. And this looks different for every patient. So we're going to jump into some scenarios, and I'm going to ask for some participation from you all as well. So this is the console. The console reads that mom is not being attentive to the baby, and there needs to be a psychosocial assessment. And so just from this information alone, I want to get some thoughts from you all about what do you think is going on here? And then two, the two-part thing, and what values or biases may be present with the referral source. And so I'll just take a moment to see what's happening in the chat here. What do you think is going on with this family based on this basic information that is presented in the console? I'll just give it a moment for people to begin to chime in.
Would you like us to
Perhaps
read
the mom is too young. I'm looking at the chat as well.
Okay, awesome.
Thank you. So the mom is too young, perhaps. Okay. So when you see that the mom is not being attentive to the baby, what are you thinking is happening? Not enough information to tell. Okay. It could be a lot of things, right? Postpartum, how the mother feels about wanting the baby. Is she scared? What did the nurse observe, or the provider who gave this, who ordered the consult, what did that person observe? The referral source may have an idea of what attention to the baby means, and may see that the teen, in their eyes, can't or are unable to appropriately parent the baby. Great responses. The birthing person could have had a traumatic experience and still recovering from that. Okay. All right. So let's take a look at what happened, what the situation was. So remember, this is what the consult was. So I went in and did a basic psychosocial assessment, which is a basic well-being assessment that looks at their mental health, their social support, their social situation, their living environment, if they have some substance use. I talk about postpartum depression and anxiety, and what that looks like, and provide them with some information there. And so the situation that I found was that the partner, the father of the baby, and the significant other of the mother that just gave birth was present and attending to both the baby and the mom's needs. During my encounter with them, I saw that I observed the mother requesting several things of her partner during the encounter. He was, running around the room, picking up this, doing this throughout the encounter. And my overall observation and assessment of the situation was that this was just a couple's relationship dynamic. The baby's needs were being met. Mom was present and was directing the needs of the baby. And the other thing that I should add was this was day one post-op, so she had a cesarean, right? So we know that mothers who had just had a cesarean have some time that they need to heal. And so I did a simple assessment, wrap things up, and let them know that I was there for support. But again, just kind of thinking about what the person who entered the consult, kind of what they were thinking about being attentive to the baby. She was present and she was directing cares, but she was also healing. So, and we have to give people time and space to do so. All right, we're going to look at another scenario. So the consult reads, there's a history of drug use, there's some substance abuse, there's prenatal exposure, and that there needs to be a child protection report. What do you think is going on here? Or what values or biases may be present? I'll give you a moment to chime in the chat. So just from these basic phrases in the consult, what do you think is happening here? Or maybe, maybe the phrases are pretty self-explanatory. I'll give folks another moment to chime in the chat. All right, so there may be a bias based on previous history, and there may just need to be a consult for care support inquiry, okay? Yes, so the birth family may be frightened that the baby will be taken away through child protection services. Some very essential questions are coming up. Was the mom still using at the time of delivery? And being mindful that drugs typically come first to an addict. And then also wondering about what prenatal care the mother received. And again, worrying about the fear of removal of her child. Great responses. All right, so this is what happened. So I went in, did an assessment, and the general assessment that I would typically do, and I learned that mom tested positive for THC at the beginning of her pregnancy, one of her prenatal visits. So it's in her prenatal records that first prenatal visit that she tested positive for THC. There was some legal recreational marijuana use, so outside of the state of Minnesota. This occurred prior to her learning that she was pregnant. And then mom and baby both tested negative at birth. All right, so kind of going back to this consult. So it does appear that there has been some drug use. Saying that the young person, this new mom, has some issues with substance abuse is not the case. There, in fact, was some prenatal exposure. And then I did not have to make a child protection report because per our hospital policies, any mom and baby that tests negative at birth, we don't make a child protection report. So what I simply did was did the assessment, informed them of the risks of prenatal exposure, particularly to THC, and those typically are premature births, low birth rate, maybe some learning disabilities along the way. But at this point, the baby was on time. The baby was healthy and being housed in the room with the family and not in the NICU. So things were going well on this end. And again, mom and baby both tested negative at birth. So this kind of just gives me pause, right, about the consults that I receive and what to do with that initial information and how to go about the assessment and then what I'm doing as a result of the assessment. So some takeaways here. And I also want to provide a disclaimer. I'm not saying that all consults to a social worker in a hospital setting are unwarranted. Many of them are, right? But sometimes we have to kind of assess what is happening for ourselves And then also remembering what our policies are in our particular setting and about what we are going to do with that information. So some takeaways from this piece is we have to be aware that there may be bias from the referral source. And I challenge you to question those who may be operating based on personal values or individual bias, and then advocating for those that have been impacted by others' personal values. And so this is not about a blame game, right? And so also being cautious of our own personal values and biases, and then not judging others based on our personal values. All right. All right. So what do you think are the needs of youth that are expecting or parenting? So these are young people that are pregnant or have a baby on the way, or our new moms just had a baby, our new parents, our new father. Maybe it's postpartum, they have taken the baby home. And what do you think some of their needs are? Put your responses in the chat. Safety and resources for the baby, definitely. Some social and emotional support, for sure. Practical baby items, right? A crib, a bassinet, diapers, clothes, bottles, and some parenting education. During the pregnancy, some information about what to expect during childbirth, and some empowerment for sure. And some excitement about the new baby that's coming. Some information on child development. Yes, all of that. Yep. All right, so we'll stop there. Postpartum, some encouragement about what's going right with their parenting experience, for sure. Yep. Information on the postpartum period, the emotional roller coaster that they may experience. They keep coming in. Okay, we'll stop there. If you have any other additional comments about this particular, what the needs are, go ahead and put them in the chat, because I'm always interested to see what other folks' perspectives are and how we can help this population. All right. So what we did at the Department of Human Services was that we convened a stakeholder work group. And so the stakeholder work group included some county, we invited county and tribal agencies, the people who particularly work with expected and parenting youth, or like a adolescent population. We invited young people with lived experience, so who are parents, some foster parents, and then also some other people at DHS that are interested in this population or kind of cross paths with this population. And so these are some of the essential services and resources that were identified for young people who are pregnant, expecting, and parenting. So again, just kind of go through the list: some childcare, early childhood education, some information on child maltreatment prevention, and then some employment support, financial support, perhaps some housing resources. Where are the baby going to live? Some life skills, again, some basic things like maternity clothes, right? One of the things that kept coming up was mentors. We thought that this was very important for this population. And then also some formal parenting education and parenting skills. And then one of the biggest pieces is some reproductive health education, learning about their bodies, and then a little bit of information about family planning. How do they determine when they want to have another baby? Do they want to explore some birth control, things of that sort? And then, as we know, with everybody, right? But particularly with adolescents, they need access to technology, and then they are going to need some access to transportation. And so these were some of the things that were identified by the stakeholder work group. And then we also developed some practical resources of how to locate these services within Minnesota, and we have that in a larger best practice guide for expectant and parenting youth. But again, a lot of the same things that you all identified as well. All right, so one of the ways that we try to address the needs of this population here in Minnesota is through what we call our minor parent case management services. So this is a prevention service case management model. So this is basically, so per Minnesota statute 257.33, when a minor gives birth, so a minor, someone who is 17 or younger gives birth, the hospital has to report it to the county of residence, and then the county of residence has to offer case management services. So this is a voluntary program. This is a voluntary service model. And so the statute also identifies various components that need to be addressed. So initially, we have to address if the young person desires to parent. Are they planning to parent themselves? Are they considering an adoption and helping them through that process? If that's the case, we must consider the age of the young person, right? So like a 12 or a 13-year-old would have very different needs than a 17-year-old. So considering that, considering the education plan, the child care plan, the involvement of the young person's parents. So kind of looking at if the young person has some support, and then establishing paternity, and then assessing what the father's involvement may be, identifying what their parenting skills are, and if they need some assistance in this area, assessing their living arrangement, right? Are they living with their parents? Are they living with their grandparents? Are they being pushed out of this living arrangement? Is the housing secure? That sort of thing. And then looking at economic support. How are they going to take care of themselves and the baby financially? And of course, their ongoing healthcare needs. This particular program is particularly near and dear to my heart because this is where both of my roles overlap, right? So I am the policy specialist at the Department of Human Services that oversees this particular policy. So I provide guidance and technical assistance to the counties about how to implement this service within their agency. And as the medical social worker at the hospital, when this occurs, I'm the person that would then inform the county. So not necessarily a report, but inform the county that the young person has given birth, and for them, in order for them to offer services. So this particular service model typically goes through social service agency. And I would say this happens about 75 to 80% of the time within our system here in Minnesota. And however, sometimes it goes directly through the public health agency of that county. And sometimes they have a dual case management model as well. If you are interested in learning more about this service model, there's a bulletin that I released about 1.5 years ago that is there, and you can get more information there. All right. This is just some some data about the number of families that have been served through the child welfare portion. So again, I am on the social service side of things, and these are just some numbers about who, the number of families that were served in these respective years. All right, so now we're gonna jump into the child welfare perspective. So when we talk about expected and parenting youth and child welfare, we're talking about young people that have been named as a child in an alleged child maltreatment case. And so these young people could be living in the home, or they could have been removed from the home and in foster care. So when we talk about expected and parenting youth involved in child welfare, we are not talking about those young people who may have allegations against them. So this is the young people named as a child. Okay. So again, here's a little bit of data. So remember that general population of females 14 to 20 in Minnesota for those respective years. And so what we did was the Department of Health birth record data is that we did a cross-examination with our social service information system data, and to figure out how many of these young people were child welfare involved. And so the top row there is the number of births to young people 14 to 20 in those respective years. The second row there are young people who were victims of child protection. So again, they were named as a child in a case before the birth of their child. And then that bottom row there are young people who were TP victims after the birth of their child. So this means that they are child welfare involved and also parenting. So we kind of wanted to take a look at, what's happening and when the births are occurring. And so this is a snapshot of the young people who have had foster care experiences and that had births before, during, or after foster care placement. All right. So again, we'll tap in and see what are the needs of youth who are expecting or parenting and involved in child welfare. And so I'll give you a moment to chime in the chat. I'll open the chat here. What do you think are the needs of this population? Yes, mentorship, definitely. Safety, yep. Anybody else? Anybody else have anything? Emotional support, mental, emotional, and social support. Yep. There seems to be a lot of need, having trouble listening. Yeah. Again, support, basic baby items, some parenting education, safe housing, healthcare, maybe some mental health support, books to help them along the way, learning to budget and shop. Yep. All great responses. Give folks another moment in case people are mid-typing. Financial support, yep. All right. So housing stability, yep, that's going to be important. Because I've seen in various scenarios, young people who are put out of their home because they are now parenting classes. Yep. So, all right, so we'll go ahead and close the chat. These are some of the things that this work group identified. So we asked the same question, right? So what are the essential services and resources for expectant parenting youth and their children who are child welfare involved? So a lot of the same things that we identified for the general population. And then we also thought that it was important to include some therapy, some transition services, so how to be independent of the child welfare system. And then this came up over and over and over again, was that we need foster care placements that will take both the young person and their child. All right, so again, a lot of the same things that we identified earlier. All right, so this same work group, I had them working, y'all. We also asked them to identify some core values, some things to help guide the work. And so we developed a long list of things, and then we narrowed it down to about 10 basic things. And then what I have before you here are just 8 of the guiding principles. The other ones were really directly related to that child protection involvement. But I thought these were the core 8 that we would discuss today. And we'll take a moment to look at those. All right. So we thought that it is ideal for anybody who works with this population to strive for cultural competence. So to be aware of their own worldview and learn about different cultural practices and worldviews. We also think that it's important that people who work with this population are developmentally informed, so that they become informed of adolescent and early childhood developmental stages, and help the youth understand their development as well as the development of their children. So this is multi-layered, right? We think it's important for workers to approach this work in a holistic way by considering the total of the youth and being aware of all of the aspects of the youth's life. So thinking about their body, their mind, their soul, the environment, all those things that make up who they are. And then also having a multi-generational approach. So supporting and providing services to both the youth and their children in a whole family approach. All right. And so we also think it's important for people who work with this population to provide the same opportunities for youth who are expectant and parenting in child welfare as those who are not. So, right, if we find ourselves in a situation where we are serving both populations, in care and not in care, keeping that in mind. And then also being sensible and practical when making decisions for young people based on their age and development. We hear this all the time. You want people to operate in a strength-based manner. We think it's important to focus on youth strengths, such as their assets, their positive attributes, and their resiliency, and just the positive things that they bring into the situation. This is another word that we hear often in this work is trauma-informed. We think it's very important that people understand the different ways that trauma affects youth in child welfare. And then we also think it's important to promote family unity. So what this looks like is asking the young person, who are your family members? What do you consider your family unit? And including all of those people. So those are the basics of our guiding principles. We do have a guide that identifies some concrete examples of how to do these things and how to carry out these guiding principles. And that can be shared with you all as well. But that's it. That's all the information that I have for you all. And now we'll just open it up for questions.
Thank you, Tamara. And I also see that we did have one question already in the Q&A. So you guys can either type it in the Q&A or type it in the chat. And we are watching to ask Tamara these questions. The first question I see here is, will they have access to these slides? I know we're recording this, but is that something?
Yes, you can have access. I did submit the PowerPoint to be provided to the attendees. So there's a lot of links and things within the presentation.
Okay. So again, if you guys have questions, please just type them in the chat. And there was one question that came up of, do you think implicit bias training is important to healthcare providers? And if so, do you have any suggestions on any implicit bias trainings that may be good for healthcare providers to attend?
Yes, definitely. Yes, very important, very essential. I don't have any particular suggestions on trainings, but a lot of healthcare systems have a lot of access to, different healthcare systems have different access to different service providers and such. So I'm sure it's available, and if it's not, it should be made available.
That's great. And I think that came up in some of the scenarios that you showed earlier today too. So
yep, definitely.
Also, what holistic approaches to services and delivery of care do you suggest are most important?
So basically, when we were talking about holistic approaches, are just kind of thinking about ways to serve the young person other than identifying them as a parenting youth, right? They have other identities. And so tapping into what that means for that young person, and then connecting them with resources related to that. So if they, if they identify as, I don't know, as Muslim, right? Connecting them with other Islamic community resources. If they identify as a part of the GLBTQ community, connecting them with those types of services. So it's really about asking the youth what's important to them, how do they identify, and what kind of services they need and supports they need around parenting.
Thanks, that's a great answer. We also have a question in the chat. It says, do you have suggestions for how to navigate the positive THC scenario? And Mary said, as a birth doula, I see this quite often, and I see a difference in the treatment for BIPOC birthing people. Good question.
Yeah, and so, yeah, the THC thing comes up quite a bit. Let me just make sure I'm answering your particular question. Okay, how to navigate this. So first, we have to go by the policies of the institution or the agency of which we're dealing with, right? So we have a policy within the MHealth system that we do not report for THC early in the pregnancy, only if they tested positive at birth. So that's a policy within the medical system, and it's also a policy on the child welfare system. So if you were to report that to the Minnesota Child Protection, they may do a basic assessment of the family, but they can't really go any further with that because there's no active ongoing THC use. And also, we have to think about, like, in this particular situation that I described, like, sometimes people use drugs and alcohol before they know that they're pregnant, right? We see that a lot with alcohol use, and we have to give people grace, right? So, so just kind of thinking about that, thinking about what the policies are, and then making sure that you're providing the education to those providers. So providing them the education about, obviously they should know about, the provider should know about the risks, but then also providing information about the ramifications on, like, maybe on the child welfare side. Like, yes, you may see this as a concern, but per child welfare policy, this is not a concern. And so just kind of operating in that way.
Thanks, Tamara.
I-
Oh, go ahead, Nicole.
I'm sorry, I had a question and I apologize. I placed something in the chat. I was having it staying there and I hit send. One of the questions I had on the slide where you talked about the task force and it had, life skills, parenting skills. I noticed it didn't have like a dominant mention of like mental health or social emotional support. You said it, but I'm wondering, is there like certain resources that are really provided for young people if they need it or express the need? They're nervous, about being a parent. Mom is putting me out. My grandma's, no longer alive. Like, is that service provided, and is there a reason why it wasn't its own topic?
So it could have just been an oversight. So a lot of the people that were involved have dual roles in child welfare and behavioral health. So that definitely came up a lot for connecting young people with mental health services, particularly those young people that are child welfare involved, because there's some trauma there, right?
Right.
So if they have been, even if it's just an allegation, there's typically some underlying issues within the home that could be addressed. If they have been removed from the home, obviously there's some trauma there. So yes, mental health is definitely a vital, very essential resource. And as I mentioned, with our larger best practice guide, we do identify how to connect young people with various mental health, with various services throughout the state of Minnesota. So yes, that was definitely a part of the conversation.
Thank you.
We had another question in the chat from Hazel. Have you used CHWs with these parenting youths?
So we haven't particularly had a relationship from the department, the Minnesota Department of Human Services perspective. We haven't had a relationship with community health workers, but we do suggest that to the counties who work with the population. And a lot of times they have like public health nurses that are part of their county agency system that they would typically use as well. So either the community health workers or public health nurses. We encourage all of that, but no direct relationship with particular programs.
Okay. Also, it says, what impact do you think COVID-19 has had on this population? And I think that's a good question too, because I know with a lot of places, they were only letting like one person attend the birth, right? If I'm correct about that.
Yep.
And so,
Yeah.
Have you seen an impact with that on this population, or?
Yes, we have. So from both perspectives. So we've just been exploring this in the last really deep dive in the last couple of weeks about how the young people on the child welfare side have been impacted by the pandemic. But yes, definitely on the medical side, because as was mentioned, only one person has been able to be in the hospital for support. So one support person for the entire stay. And then in those instances, we have been encouraging technology use and providing like iPads in the room for them to connect with family members. And then, you know, a lot of young people have smartphones and they can, you know, tap into their supports that way. But there's been a lot of sense of loneliness. I mean, because, you know, they are essentially by themselves throughout their hospital stay. And so we have also seen an increase in births in general, right? And so I am now this week taking a look at the data to see has there been an increase in those child welfare involved youth as well. So more to come on that piece.
Yeah, I wonder if there's been an increase in doulas too. I don't know if you've seen an increase in doulas since I think, can they also have a doula with them in addition to the one?
Yep. Yep. Per the hospital policy, they can have a doula. I haven't seen much of that in my cases. But again, I'm not there full time. I'm there as a casual social worker. So I don't see every single, you know, mom that comes through. But yeah, doulas are able to be there in addition to one support person.
Thank you. And I'm not seeing any more questions coming in. So I think I can pass it to Nicole if that's the case.
Awesome.
But thank you so much. It was an amazing presentation.
Thank you so much, Tamara. We appreciate you so much. I, having worked in with youth previous, this is really helpful to know this valuable information. And I consider myself to be a support of young people, but I did not know the reporting age, right, for support. That they could get support if they're minors, even for families, sometimes for moms and families, if they have a young person that is pregnant, they need support too and resources for them. They want to make sure they finish school and, you know, they still have dreams and so many goals. So I just really appreciate the information that you shared. And also for our moms and those that we serve in our community to just sometimes given resources, right? It's power and things cannot feel so overwhelming. So I truly appreciate your expertise meeting this way in this intersectionality for the benefit of us as participants. I want to thank you again for your time today. I did place in the chat the next upcoming maternal infant health series. I will send a survey out to everyone within about 24 hours. And once I get the surveys back, we'll be able to send out those slides. Any other final things you'd like to say before you go?
Thank you for inviting me. It was a pleasure to kind of share both of my roles. I've been working with this population in various capacities for a long time. So I'm happy to share any additional resources that I may have. Feel free to reach out to me if it's a child welfare involved sort of situation. Feel free to reach out to me on my state email address there. If it's a medical sort of question or way that you would like to connect, there's my Fairview email address as well.
Wonderful. Thank you so much for sharing your emails with us and with the community that is here. We wish you well and take care.
Thanks. Bye.
Thank you everyone for attending again on an upcoming maternal infant health series. Take care. Have a great afternoon.